All right, here we go. It is week 10. It is Wednesday. It's winter 2021. The dreaded, the feared spinal biomechanics lecture. I cut all the other stuff out, so this is all we're going to do today. But it's kind of complicated if you never had biomechanics. If you had biomechanics, you're good to go. Important concepts to bring back from the very first lecture. Remember the different planes of the body? So we've talked a lot about this sagittal plane right here. So this is a mid-sagittal cut, which goes right through the tip of the nose. You can see the cut right there, right? And then we have the axial. Hopefully everybody understands that by now. I'm sure you do. So remember, these planes are viewed, and they're not viewed the same way they're cut. It's cut like this, or it chops your body in half, but you have to get overhead to kind of, there's a camera. You get overhead to view that axial plane. Sagittal, you go from the side to view the sagittal plane. That one's, and what else we got? We have coronal plane, and we could do that in green. Have a good day. And there's the coronal plane right there. All right, we're all good with that. So that's like cutting you right through your ear. There's the cut line, right through the point of your shoulder. All right, and then that one's best viewed out here from the front. All right, so we're all good on that, I'm sure. So true spine experts, they have to understand biomechanics of the spine. And in order to understand biomechanics of the spine, you have to understand the biomechanical planes and the biomechanical motions and movements. And the term, the biomechanics, I mean, maybe one of you or two of you might get into biomechanics and start to do research and publish papers on it. It's a fascinating field. But the terminology is a little different than the terms that all of you will use, commonly will use. Like, for example, flexion and extension. These are the classic clinical planes of motion. Flexion, and you can measure lumbar flexion, thoracic flexion, cervical flexion. And if you work for the state of California and you do evaluations on injured workers, you have to report these planes of motion. Same with lateral bending, same with rotation. Those are the ones you'll use clinically speaking. But if you're a biomechanist, this is not really flexion and extension. This is sagittal rotation. This is anterior sagittal rotation. This is posterior sagittal rotation. So we got some of you have some different lingo to learn here. So in a way it's kind of easy because there's only two types of motion that a vertebrae, if we talk just about a single vertebrae, or that's what we're going to talk about, is a single vertebrae, its range of motion. There's only two types that it can undergo. It can undergo a combination of these as well. But there's only translation and rotation. That's it. Translation is slide. It's like sliding something. So if we have a, let's see, there it is. If we have a surface, not very straight, but if it's a flat surface, well, even if it's not a flat surface, if we push a block over a surface and it slides this way, that's called a translational movement, or you could call it a forward or an anterior translational movement. If we stick a peg in the block, let's take the block again, and we put a nail and nail it to the wall, and then we push on the corner or two corners, the block wouldn't translate, it would rotate. And so that's a rotational motion. So it twists around an axis or a plane. This one, or within a plane, this one slides along an axis or slides along a plane. What are these axes? Well, these are the ones you learned in math. So there's the x, the y, and the z axis. So we can have translation along the x, y, and z axis, or we can have rotation along the x, y, and z axis. Or if we turn the axis into a plane, we can have a movement along that plane as well. All right, there's Mr. Bill helping us out here. So remember these from, I'm sure you know these already, but if you stick your arms straight out like an airplane, that's your x-axis. X negative, X positive would be over here. Then if you shot an arrow through your back, went forward, that's your z-axis. X, z positive, z negative back here. And then if you put one right through the crown of your head and out your you-know-what, that would be your y-axis. All right. So translation, as we just said already, but here's a much better picture. So that occurs when you slide over a surface. So when forces, you could take a force and push. Let's say we could have one force pushing here, Ant-Man, and there's Ant-Man number 2 is pushing down here, and Ant-Man number 3. So there's 3 forces. When those forces all push in the same direction, you get a translation. And the vertebrae will move in the same direction, in the same plane, and each, if you select a point on any point on this vertebrae, in a translational movement, that point will move exactly the same direction. So this moved 5 millimeters. Every one of these points will move 5 millimeters. And that's not true with rotation. So no rotation can occur when we're talking about this rule, though. Because if rotation is occurring at the same time, then these points can move different degrees. Shear force. So a sliding, well, defined, any force that causes a translational motion is called a shear force. And why is that? Because the surface that the vertebrae is dragging over creates a shear on that surface, or a dragging. That's a shear force. And the shear force, as we've learned in physics, causes a friction, which is a buildup of heat energy. Why do we care about this? Because people with hyperlordosis, and especially in the lumbar spine, that causes a shear force on the discs and on the pars interarticularis, and it causes spondylolisthesis, and it causes annular tears, and it causes more trouble at L4 and L5 because of a shear force. And for example, here's a lateral view, an X-ray of someone with a, well, somebody you tell me. I would say write it in the comments, but I doubt if anybody would write it in the comments. So you're probably studying for something. But this is spondylo, right? Spondylolisthesis, almost a grade 2 slip. But there's a hill here. See S1? Look at the plane of the superior end plate of S1. That's like a hill, and we have L5 constantly sliding down the hill. So the weight of gravity pushing down is pushing this along a flat surface. So it acts as a shear force, and it stresses the pars interarticularis back here, and it can fracture, or help it fracture, and it can fracture the discs in here. So that's an abnormal shear force, and that's how that works. Now rotation occurs when at least 2 forces act on a vertebrae at different points, and that causes a rotational motion. So we have in this cartoon, we have one force pushing this corner, and we have one force pushing this corner. Now they don't have to be 2 pushing forces. This could be a ligament holding this, but it still acts as a force at this corner, as long as we have one pushing force going on here. That will cause a rotation. And rotation will have that the points on the block will move different degrees. And that movement, this movement right here, that's called an arc. And the farther away you get from this very center, which is called the center of rotation, the greater the arc will be. The center has no arc. has no movement at all. That would be the perfect center of rotation, right? So a point way out here would have a much greater arc. A point right here, you can see it doesn't have much arc. So that's different than a translation. Coupling. So rotational forces, you can add them together, and those are called coupled forces. So here we have force 1 pushing here and force 2. You can add force 1 and force 2 together, and they help the rotation occur, and those are called coupled forces. And we talked about the center of rotation already. So the net of the coupled forces is called torque. So you can add these forces together to create what's called torque and calculate the torque. It's got a lot of AKAs for that word, torque. Rotational force is an AKA for torque some authors use. You'll be using this as you go through the program when you get up higher. Just kind of introducing these terms. We're not going to calculate any torque or anything like that now. I don't know if they'll have you do that when you get, maybe they will when you get up higher. The torque results from two different forces acting on the body, causes a rotation. We already said this. May also result from one force and one resistance, so that still maybe can subtract away from torque. And gravity can, of course, act as a force to cause torque as well. Center of rotation, like if this is a bone, let's just make it a run-of-the-mill bone here. So when a bone rotates, like if you rotate your humerus back and forth, external and internal rotation, different ports, same as everything we said, different points will have different rotational excursion. You're still going to have a kind of an axis of rotation or a center of rotation. And I think we said everything else already. Another concept is that all points rotate in the same plane. So, yep. So let's go back to this. So if this is a pure rotational force, maybe this is the coronal plane, but they're all rotating in one plane. You don't have different points rotating in a different plane with a pure rotational force. Even on this picture, if we draw a point here, and it's rotating this way, creating an arc, and we draw a point back here on the bone, they're still rotating in exactly the same plane as the point that I'm trying to make there. The axis of rotation, so that's kind of the center of rotation. It has no excursion. Definition, it's the points on a rotating bone that don't move. We've already said that, so we got that. Axis of rotation is typically perpendicular to the plane of rotation. All right, so let's get into planes of motion. Now, all planes of motion, especially when we're talking about our vertebrae, are described in the anatomical position. You already know that from anatomy. So if I made a giant vertebrae here, this is the anatomical position of the vertebrae. We can't see the spinous process from this view, but we can see the body and the transverse process. From this view, you can see the spinous process. You can also see the body, and you can see the transverse processes. So you can see the spinous process, transverse processes, and you can't see the spinous process in this view. So that's the anatomical position of a vertebrae. Right, and there's a better drawing. So these are, we've studied atlas and axis a lot, and the vertebrae and the Luschka joints and such. These are the anatomical positions from an A to P perspective. Got it? So who are these biomechanical planes of motion? So we have forward and backwards. So they still occur in movements that we already know. I didn't go through these because you know these, but you can, like, there's an anterior translation, a posterior translation. You could call the forward translation. You could call it backwards. You could call it a cephalad, a caudal, superior, inferior. So we can use those terms, those directional terms, to describe rotation and translation. So there's a medial and lateral, lateral to medial, right bending, lateral flexion, left bending, left bending, and those are both lateral flexion. That would be left lateral flexion. That would be right lateral flexion. There's upwards motion, superior motion, downwards motion, twisting, rotation. So these are all terms that we can apply to our rotation and translation. Again, the three biomechanical axes are the X, Y, and Z. That's how you should always describe biomechanical motions of a block or of a vertebrae or whatever. We looked at these already. So I think you're probably good. Remember, posterior, left lateral, inferior, right lateral, you can't see. Superior, you can't see the surface. And we did those already. You could probably take that slide out. Now, if we add those to a vertebrae, they're the same motion. So translation, there's the z-axis. So we could slide along the z-axis. If you imagine the z-axis in a axial plane, or I shouldn't really use the word axial, in a horizontal plane. I'm not very good at drawing planes, but so if you pushed and slid the vertebrae forward, it would slide along the z-axis, but it would also be sliding along a transverse plane or horizontal or axial plane. We shouldn't use axial because they use the word axial to go more with this y-axis, and I'll explain that later. Because you know hat, right? Or chat. What's chat stand for? So those are the AKAs from this bird's eye view. Cross-sectional, which we really don't use. Horizontal, axial, and transverse. So we can use all those to describe that plane, but don't use this one. That's going to be safe for something else. So anyway, those are the planes, and you can give them positive and negative directions. So to the left is always positive. That's negative. To the right, like a translational movement, a lateral translational movement to the left would give you a positive translation, and to the right would give you a negative translation. And up is positive, down is negative, posterior is negative as well. Alright, so pretty simple so far. Translation versus rotation. So there's generally, again, two types of motion. We're just reviewing. Translation is a sliding motion. Slides over one axis or one plane. Rotation is a spinning motion. Alright, now we're ready to meet the actual movements. So first one we'll talk about is A to P sagittal translation. And so in A to P sagittal translation, let's just look at a picture of it. Sagittal translation is the one we're just talking about, where the vertebrae could move forward or slide forward on the z-plane. So if you stuck a pole through the vertebrae, it would slide forward on that pole, or it could slide backwards on that pole. So if it slides forward, that's called anterior sagittal translation. If it slides backwards, that's called posterior sagittal translation, right? And we could put that plane in there if we wanted as well. So this sliding is occurring. Let's go back here. Is occurring more on a horizontal type plane. But that might just confuse you. Just think of sticking a pole through there. If you stick a stick through there, it's going to slide in this direction. It can't rotate at all. It's just sliding in that plane. So that's everything I said. Now, sometimes it's a gliding motion is the same as a translation. Some call it a sliding. Some call it a translating motion. Those are all the same thing. The key is it moves along the z-axis, either forwards or backwards. And it's an anterior sagittal translation. Some designate that a positive sagittal translation and a posterior sagittal translation, or a negative sagittal translation. So you can substitute negative for posterior, and it still means the same thing. All right. And let's see. So how do you remember this is a sagittal translation? That's the hard part for students. Why is it sagittal? How come this isn't a coronal translation? So it's a sagittal translation. I think of it as the best way to visualize this movement is by standing on the side and watching it happen. You could fly overhead and look down and see the motion, but that's reserved for other stuff. So the sagittal sliding is best seen from the side, and I just memorized that. And I mean, it can slide in the sagittal plane is another way, but I can slide in a horizontal plane, so that doesn't really work. So you just have to memorize that that the sliding back and forth is best visualized from the side, and that would be a sagittal cut. Okay. You could also say it slides in a sagittal plane. So it's just I just memorize it. From the sagittal plane, you can see slip, forward, back, slip, and you can also see rotation, because there will also be sagittal rotation, which is bending forward and bending backwards. So that's always confusing, and you're just going to have to figure that one out. Okay, so why sagittal? Because it's best observed in a sagittal or lateral view. That's how I remember it. And yes, excessive sagittal motion of one vertebrae on the other can definitely cause a pain, and that's something you take flexion extension x-rays to look for. I think we're going to go in a little rabbit hole because this is such an important motion here. So normally, if you think of a sagittal motion, let's say this is C5 and C6. So if you push the vertebrae back here and want to create an anterior sagittal translation, it doesn't happen normally because of the way the facet joints are. So this inferior articular process is going to bang into the superior articular process of the bone below. So you normally don't have any anterior sagittal translation. If you push the vertebrae this way, there's a capsule around here, right? And you have a lot of muscle. You have ligamentum flavum. So you're not going to have normally any independent sagittal, either anterior or sagittal translation. If you are slipping back and forth, that can irritate these facet joints and be a source of chronic pain. It can also irritate if you have a rip in the disc here. It can also be very irritating to the disc. So those are things we look for by doing a flexion extension. In this case, we'd order a cervical flexion extension study to look for any type of anterior posterior sagittal translation. Everybody got that? It's a very important concept. You'll take that with you for the rest of your careers. So it's well known that sagittal rotation actually causes sagittal translation. So if we go back to that, sagittal rotation we haven't officially talked about yet, but that's when you touch your chin to your sternum, or flex your cervical spine forward. That's an anterior sagittal rotation. When you do that, it also imparts, or it tries to impart, a anterior sagittal translational force as well. So when you rotate the vertebrae, it automatically tries to push the vertebrae forward. It can't because of these facet joints, but it tries. So therefore, cervical forward flexion, or if you're a biomechanist, sagittal rotation, anterior sagittal rotation, always is coupled with anterior translation, anterior sagittal translation. So those two forces are coupled together, right? So it's well known that sagittal rotation causes sagittal translation. All right, so posterior causes posterior, anterior causes anterior. And so this is called coupling. Everybody understand that? Coupling. We can measure this amount of anterior posterior sagittal translation, and you will do this. When you order those flexion extension studies, you have to see how much slip there is, how much anterior and posterior sagittal translation is there. And once you measure that distance, that's called the excursion. If it's greater than or equal to 3 millimeters, it's a rateable disability. It's an add-on disability in California because they know that's associated with chronic pain. If it gets greater than 5 millimeters, surgeons start getting excited because that's a cause of severe chronic pain that may necessitate some type of interbody fusion procedure to stop that. If the patient has 3 millimeters or more, they're said to be unstable. That's where that word comes. Oh yeah, the patient has cervical instability. What does that mean? That usually means that they are unstable with regard to sagittal translation. They're slip sliding back and forth. There's a lateral translational instability as well, which we're going to look at. All right, so important concept. So here is a cadaver. This is an experiment that was done. And in the lab, they rotated the bone forward. And we know that if you do sagittal rotation, here's the original point. I guess I can mess this up for a minute. So there's the resting point. And then they applied a force like this to rotate the bone forward, and they took another picture. And we know normally there would be no slip forward, but in this case you can see we had this much slip. You can actually measure that from here to here. So we had 7 millimeters of slip, which isn't supposed to happen. So there's either the facet joints are broken or there's a fracture in the pars. That's where a spondylo is created. Okay, see how that works? So it's way over 3.5 millimeters. So this patient's probably going to have surgery. That's a lot of slip. Right? And why does that happen? That's because these two forces are coupled. The anterior sagittal translational force is coupled with the anterior sagittal rotational force. Normally there would be no movement. If we did this to you, we took an x-ray of you bending forward and an x-ray of you bending backwards, you wouldn't have any slip like this. And you're going to use that tool all the time in practice. So here's a real case, 53-year-old patient. She was told, she came to me for a second opinion. She had horrible chronic back pain, was losing her house, couldn't work, bilateral lower extremity pain, not in this country. And this was out of the country case, which I have many out of the country, probably more out of the country than in the country cases. She was told she is not a surgical candidate. She had an Oswestry Disability Index of 55, which is a pretty disabling level. And she came to me and I said, where's the flexion extension study? You're not a candidate for any type of fusion. Where's the flexion? So we ordered a flexion extension study. And here is the real flexion extension study. Not the greatest quality in this country, but nevertheless, things kind of went a little backwards on this case. So when she extended, she actually had this much translation. So you drop a line down from the posterior corner, and you'll learn how to do this more. There's the S1 segment here. There's L5. And then you measure the very back of the S1 segment would be right there. And it came out to 8.5 millimeters. And then when she flexed, usually they go forward when they flex, but sometimes it's reverse, but it doesn't matter. When she flexed, it still wasn't perfect. There was 1.6 millimeters of positive sagittal translation still. And so we have to subtract those two to get the bottom line. I want to know how much is she slipping and sliding. She's slipping and sliding from here to here. So we need to do a little math. 8.5 minus 1.6. So about 7 millimeters of anterior sagittal translation, or translational instability, or excursion is actually the name for that. And that's no good. That's crazy. That's a crazy amount. And so she did end up, we got her, she went out of the country, she flew to Germany and had a very successful surgery. Last I heard, she's doing great. Not perfect. No one's usually not perfect. The average score on the Oswestry is about a 24, 25%. disability on that test following surgery. Tiger Woods got 100% until he messed up his back because he continued golfing and he didn't obey his limitations that everybody has after a fusion. You do that, you're going to blow the disc above, and that's exactly what he did. But nevertheless, trouble with fusion, kind of getting off on a tangent here, but the curve is bell-shaped for fusion. And so normally most people after a single level fusion get about, we'll just say 25%, and you start going a couple standard deviations in any direction. So Tiger Woods is way over here, maybe 2, maybe even 3 standard deviations away to the good side. Very low oswestry disability. Some people can get 50, they can get 80. I mean, I have people who are suicidal I talk to. So fusion's a very serious business. Anyway, I digress. Okay, horizontal. Now we're going to look from a bird's eye view and see what we can see. So you just have to memorize this. When you go above and look down at a vertebrae, that's going to be assessing lateral translation, lateral slip back and forth. And you just, I don't know any way to really, I just memorize it. You just had to memorize that. So in an overhead view, that's horizontal translation is observed. So it's called lateral slide or lateral translation or lateral slip. In practice, you tend to tell the patient, oh, you got some slip, some lateral slip here. And that's when a vertebrae slides along the horizontal plane laterally, either to the left or to the right. So we're talking about the z-axis. So there's a study card. Horizontal translation. Which way is the slip occurring? It's occurring on the x-axis. That's where we're observing this here. So there's a left to right horizontal translation. Now the AKAs for horizontal, one of them is axial translation. While that's technically okay, I said don't use the word axial, because axial is more describing the y-axis, up and down the y-axis. And I know that's just always confusing for people. So this is one instance where horizontal and axial don't mean the same thing when we're talking about biomechanics. So again, this lateral slip to the side is, just remember, it's best seen from an overhead view. I mean, we can see it from a P to A view as well. We can see it from many views, but just remember it's horizontal for lateral slip. Okay, biomechanical speak, the translation occurs on the x-axis to the right. By convention, a horizontal slip to the left is designated as positive. A slip to the right in the horizontal plane is designated a negative slip. So you have a left horizontal translation, also called left lateral slide or left lateral slip, and you have a right horizontal translation, also called right lateral slide, or any combination of these words. Right lateral translation, right lateral slip, all mean the same thing. Technically, you shouldn't call it slip though. Okay, so there's a pole sticking into the vertebrae and it's sliding back and forth on the x-axis. And that is a horizontal translation. Because you're a bird, you're over the head watching this slip from a horizontal perspective. Right? You can also say it's slipping in over a horizontal plane is another way to look at that one, because it can't slip for sure. If you drew the planes in here, it can't slip in a sagittal plane. It could slip and slide right over that. Let's see. All right, some people can have horizontal translational instability. Yes, they can. People with scoliosis, I see this all the time. So people have lateral slip with scoliosis, and you have to watch out because that can also be unstable. Anything, again, greater than or equal to 3.5 millimeters thought to be pathological source of back pain with regard to horizontal translational instability or lateral slip. Nobody calls it that in practice. They call it, it's called lateral translational instability, or lateral slip is what really honestly most people call it. Right, here's a patient at A to P view. pretty wicked curve there. Well, I guess they don't teach the Lenke scoliosis system anymore. You can watch my YouTube video on that if you really want to know how to classify scoliosis. There's a simple way they teach you. But that's a scoliosis. And you have to watch out. People with scoliosis are prone to have these lateral slips or horizontal translational instability. And so here's a 24-year-old female. You can look, you can see she's got a scoliosis. One scapula is kind of flat and the other one's kind of poking out. Shoulders aren't perfectly level. Take an x-ray of her. She's pretty twisted. Can you fix this, by the way? Can chiropractors fix this? Despite what YouTube says, you're not going to be able to fix this thing. Can spine surgeons fix this thing? Spine surgeons can really fix this thing. And here's the case. Right? So it's it's called the anterior intersegmental fusion. It's kind of misleading. They cut the patient from the side. And they go in from the side, so in this case there's just one set of pedicle screws and one rod, and she's pretty darn straight, right? You can really get people straight. Hips are still a little off, so she's not perfect, but she's way happier like this. It's called anterior because the anterior columns are stabilized. They're pedicle screws, but they actually go into the vertebral bodies. That's kind of beyond us right now, but here's a real case of mine. 55-year-old, disabling low back pain, refractory. What's that mean? Refractory or recalcitrant. Those are two words you should know. Refractory, recalcitrant. That means they were resistant to conservative care. They failed conservative care. Brings in his MRI, and what do you think? Feel free to write it down in the comments if anybody's still with me. This is the A to P or coronal view. Psoas muscles are here. Kidneys are out there. Look at the corners. How do the corners look? Well, they have bone spurs, right? They've got little points coming off, so it makes it a little hard. You have to take away the bone spur. But this bone is in place. This bone's pretty much in place. Now some of you see it. This one's, oh my goodness, right? We got a lateral slip there. Or officially we have a overhead. So it's called a horizontal translational slip on this patient. See how that works? Then you do a lateral bending study. Have them bend this way, take pictures, have them bend that way. Maybe it's stable. Maybe there's no slip here. This one is so bad that it's causing a massive biomechanical mess. So the patient ended up having fusion to straighten this spine out. But if you did lateral bending studies, maybe the bone will slip way back to here. And then you got way more than 3 millimeters. That's definitely a source of pain and can be a source of sciatica as well. Yep, so they had a severe left horizontal translational malposition of L3 in that position. We didn't do flexion extension because it was so bad it didn't matter. In clinical practices, this is called not a spondylolisthesis, but a lateral listhesis, meaning lateral slip. That's probably going to be on your test. Lateral listhesis. Technically, what is a lateral listhesis? It's a horizontal translational malposition. Got it? All right. Let's go to the front plane. Now in the front plane, we are viewing the bones sliding up or sliding down on a pole that's sticking straight out of the top of the head. So that's the y-axis. So that's where we're observing distraction and compression really forces. So, but that's called coronal because we're looking at the coronal plane from the front, coronal translation. So the vertebrae moves up or moves down. It stays sliding on the y-axis. Or you could say it's sliding in a coronal plane. That's probably not the best to say though, but I mean, that helps. It slides. If you slice the coronal plane, it slides. Because technically it could still slide up and down in a sagittal plane, so that's probably, I just put those in last night, and I thought, oh, that's a better way to explain it, but that doesn't work because it could slide in a sagittal plane. It couldn't slide in a horizontal plane, though, but so you just have to think it slides up and down on the y-axis is the way to do that. So you can have a upward slide, so that's called cephalad toward the head coronal translation. Also, you could call that a positive coronal translation, or a superior, could have put in a superior coronal translation, or an inferior coronal translation, which is a negative coronal translation. You're actually going to use this in practice to treat people. This cephalad coronal translation, you're going to be imparting on people's cervical spines all the time. And yep, so the vertebrae slides up, that's a positive, slides down, it's a negative. The key is, remember, you position yourself in the front to see this, and you picture the bone sliding up is cephalad coronal translation. Picture the bone sliding down, or really compressing it down, that's a caudal coronal translation. All right, so cephalad coronal translation we use all the time. That's distraction. And this is where the term axial comes in, because this is the long axis. This is also, this y-axis is called the long axis of the spine and the long axis of the body. And so we're moving a bone in that long axis. So it gets the word axial distraction, or axial cephalad axial translation, or longitudinal distraction. Those are all the same things as cephalad coronal translation. So it's used in therapy. Physical therapists use this when you grab somebody's head and just traction it in the y-axis. You're doing traction. Cervical traction is the short for that. Cox flexion distraction is one form of cephalad and coronal. Cephalad or caudal coronal translation is used by Cox flexion distraction in combination with flexion extension. And you can send patients home with this. Patients with a nerve that's kind of irritated in the frame, and maybe they have bone spurs in the frame, and you can send them home with this little home traction unit. But this is really, I mean, this is called a home traction unit, but technically this is, when you put water in this, it pushes down and it pulls, see the little pulleys? It pulls this up and it stretches the patient's head up. And that's called cephalad coronal translation force. We really just call that the home traction unit or axial distraction unit. Right. So caudal this one is not used as much. So caudal, that means toward the tail, toward the coccyx, coronal translation. That's a force pushing down. So if the patient was standing, we would have a 25-pound plate on top of her head. I don't know why you would do this, but that would be a force pushing down. So that is toward the tail, so that's a caudal coronal translational force. Okay, and it's not really used that much by clinicians. It's more used by, replaced with a caudal axial translation. It is the same thing as caudal coronal translation. Commonly known as longitudinal or axial compression. Cross traction, if you'll learn the cross traction technique, where you can impart, you can kind of pull a bone apart by putting kind of cross tractioning, let's say L4, L5. You can put one hand on the sacrum and pushing inferiorly, and the other hand pushing superiorly, and you get both forces. You get a caudal and you get a cephalad coronal translation by using a cross-tractional method. I know this stuff is hard. I know. I hear some of you moaning and groaning. Yeah, so that's a cross-tractional force. So this would be a force, a cephalad going toward the head. So that's a cephalad, and we view this in the coronal plane, cephalad coronal translation, and this force is experiencing caudal toward the tail coronal translation. All right, sagittal rotation, let's come back to that. We talked about it a little bit, so we need to move our camera to the side of the patient, And if you bend forward, that's the anterior sagittal rotation. If you bend backwards, the posterior sagittal rotation. This rotation, excuse me, this rotation is occurring along the x-axis. All right, so yeah, so when you bend forward, that's anterior sagittal rotation, and posterior sagittal rotation when you bend backwards. Simple as that. And we already said the anterior and posterior sagittal rotation are coupled with anterior and posterior sagittal translation. So when you bend forward, it imparts an anterior translational force. When you bend backwards, it imparts a posterior sagittal translational force. So sagittal rotation is always coupled with sagittal translation. That's a note card. Sagittal rotational forces or movements are always coupled with sagittal translational forces, and we've already explained that. All right, so when you bend forward, that's anterior sagittal rotation. So the vertebrae are all experiencing anterior sagittal rotation here. Maybe not her spine. If she touched her chin to her sternum, then the whole spine, all the vertebrae would be under sagittal anterior rotation. Right? And there's a backwards bending. Well, all the vertebrae are now experiencing a posterior sagittal rotation. But remember, they're also experiencing, they're probably not doing it, but there are those translational forces going as well. She's experiencing a translational force. All right. What about, we got one more to talk about, coronal rotation. So coronal rotation is lateral bending to the side, or if you go through a cervical vertebrae, it's lateral bending of the neck. So it's, or side bending. And this coronal rotation is best seen in the z-axis. Okay, z-axis. All right, and there's a left and right coronal rotation. So for sagittal rotation, forward and backward bending, you have to observe them from the side. For coronal rotation, you need to stand in the front or in the back and observe the coronal plane. Right? And what else was in the coronal plane that we observed? Anybody's brain able to comprehend this stuff? So we have translation up, translation down. So we have an axial compression, axial distraction are also called coronal translation. Right? But that was Cephalad and Caudal coronal translation. But now we're back in that same view, and now we're bending to the sides. So this is a coronal rotation. This is commonly known as lateral bending around the z-axis, we said. So this is an example of lateral bending, but really it's an example of right coronal rotation. All the vertebrae, except for the neck, looks pretty straight. All the vertebrae are bending to the side, bending to the right, or laterally flexing to the right. So that's right coronal rotation. By convention, if you go to the left, that's a negative. If you go to the right, that's a positive. Right. And let's see. Yep. So this one, so we talked about kind of a lateral translational slip, which is viewed from where? Where do you see lateral slip? Lateral listhesis. That's viewed from overhead. So that's horizontal translation. So coronal rotation is coupled with horizontal translation. So when you bend to the left, the vertebrae wants to translate. Usually wants to translate away, to slip away, to translate to the right. But I've seen cases where it goes both ways. But the point is it's coupled. So coronal rotation is coupled with horizontal translation. Right? And that's why you order lateral bending exercises to see if there is any horizontal slip going on. Right, so we did that. Horizontal rotation, well, I guess we have one more. So we have to go back overhead now. So what was the other horizontal one we had? Well, we said horizontal translation, right? So that we go overhead to see the lateral slip. So you can also see rotation in the horizontal plane as well. So those are the two. So make note cards on those. Horizontal rotation, so that's just twisting to the right and twisting to the left. So there's right and left horizontal rotation, and twisting of the trunk or twisting of the head. And that motion is not coupled with anything. That's a good question. Left rotation, left horizontal rotation is positive rotation. Positive horizontal rotation. Right horizontal rotation is called negative horizontal rotation if you're a hardcore biomechanist. And yeah, so what pole could we possibly twist around if we're twisting like this? Well, there's only one pole, and it has to be this pole right here, the y-axis. So horizontal rotation occurs in the y-axis. Those are questions that you need to know. Those are what I'm going to ask you. Horizontal rotation occurs in blank axis, and I'll have x, z, y, and w. That's an exact question on the test. So that's the kind of stuff you need to know. All right, axial movement. So I said we don't use axial because of this section right here. So the word axial, you think of like an overhead view, but you don't. In biomechanics, axial means this long axis, or the y-axis of the spine. So sliding up and down the y-axis is also called axial movement. And I know that's really confusing because axial is an overhead type view. So you can substitute that word axial in there. So axial rotation can replace horizontal rotation. If you remember, the axis is just the y-axis or the long axis of the body, you can twist a vertebrae. So there is an axial rotation twisting around there. General consensus is to use the word right and left axial rotation nowadays instead of right and left horizontal rotation. They're still AKAs, but most biomechanics will call axial rotation, instead they'll use that term instead of horizontal rotation. Axial rotation still means right or left rotation along the long axis of the body. Yep. So that one's pretty simple, I think. Axial translation, what about that? Does that replace, because you can think of the bone sliding up that y-axis. Well, that we said that was coronal translation, but you could also say it's axial translation. So you can have axial rotation, axial translation replacing those old hardcore biomechanist terms. Even though they're still AKs, you have to know both of them though. But that's confusing because axial is, again, is AK for horizontal. So yeah. So the general consensus now is to use the word cephalad axial translation instead of coronal translation, cephalad coronal translation. They do tend to use the word axial, but just remember where it came from. It came from that cephalad translation. What about caudal? Still confusion. Some modern biomechanics, they don't like the word cephalad and caudal, so they still get confused, and clinicians get confused when it's applied to coronal translation. And so now they use some more colloquial terms like upward. So upward coronal translation or upward axial translation instead of cephalad. Those are still AKAs because they mean up. And now they use downward coronal translation, which is of course compression, or downward axial translation. Right? So those you have to, yeah. And I know this is a lot, so go back through this and think about it, and you might have to listen to this one. But this is really, I will tell you, this stuff is definitely on boards. From being a member and seeing the board questions with my own eyes, over 1,500 questions I saw. This biomechanics is definitely on the boards. You have to know this stuff. What about flexion extension? With regard to motion, the segment, so I should point this out. So flexion and extension by themselves really only apply to the lumbar, thoracic, and cervical spine. Because the motions are coupled together, you don't really have a pure flexion and extension. There's always a translation in there as well. So you shouldn't really talk about, I mean, even though we do to test you and stuff, just keep that in mind that those are coupled together. We've talked about that, right? Flexion extension are not pure. They're always coupled with sagittal translation. And bottom line, you should not talk about flexion extension of a single motion segment. It's better to talk about flexion extension of the entire lumbar or cervical or thoracic spine. Whew, I know this is a tough lecture. All right, I'm going to close down shop. You guys can take off. If anybody's still here, I'll be around for questions if you have questions. But let me shut things down here.